Okay, so you want to own an ambulance company. You picture a white vehicle racing through traffic with its lights flashing and siren cutting through the street. Two clinicians arrive, stabilize the patient, load the stretcher, and drive toward the nearest appropriate hospital. A bill later arrives for hundreds or thousands of dollars. From the outside, the business looks almost impossible to lose money on. The customer rarely chooses the moment. The service feels urgent. The price is difficult to compare while someone is having a medical emergency. That is the dream, and is not entirely wrong. The problem is that the most expensive part of an ambulance call begins before the patient ever enters the vehicle. A trained crew must already be available. The ambulance must be fueled, disinfected, inspected, stocked, insured, licensed, and positioned close enough to meet a response time requirement. Those costs continue while the crew waits. They continue when a call is canceled. They can continue when the patient refuses transport after the ambulance arrives. Under Medicare's traditional ground ambulance fee schedule, a response normally generates payment only when it results in a covered transport. The company sells readiness every minute. Many payers pay only for the ride. That contradiction is the entire business. Before discussing revenue, we need to define what an ambulance company actually is. A city fire department operating ambulances is not the same business as a private company holding an exclusive 911 contract. A hospital-owned fleet moving patients between facilities is different from an independent operator serving nursing homes and dialysis centers. A basic life support unit is different from an advanced life support ambulance carrying a paramedic and more sophisticated equipment. A specialty care transport can move a critically ill patient who requires hospital-level monitoring during the trip. This is the first thing most buyers misunderstand. You are not simply buying an ambulance. You are buying permission to operate, trained labor, dispatch access, payer relationships, and a position inside a local emergency system. A private operator may need state licensing, vehicle permits, medical oversight, inspections, insurance, and approval to serve a particular market. The most valuable opportunity may be an exclusive or preferred 911 contract. That contract can direct emergency calls toward the company. It can also impose response time standards, staffing rules, equipment requirements, reporting obligations, and maximum charges. Winning the contract does not guarantee profit. A company can win by promising more coverage for less money than the system actually costs. The contract creates access to demand. It can also lock the operator into an expensive promise. Now, look at the ambulance itself. A working unit needs more than a chassis and a box. It carries a stretcher, oxygen, suction, airway equipment, medications, monitors, defibrillation equipment, trauma supplies, infection control materials, communications equipment, and secured storage. The company also needs spare vehicles. An ambulance cannot simply remain in service after a collision, transmission failure, electrical problem, or medical equipment defect. If one frontline vehicle leaves the road, a spare must replace it quickly. Otherwise, the service area loses coverage while payroll continues. That creates the first financial trap. The company does not earn money by owning ambulances. It earns money by keeping staffed ambulances available for dispatch. A vehicle without a crew is park capital. A crew without a reliable vehicle is paid readiness with no transport capacity. Now consider labor. Every frontline ambulance normally needs at least 2 qualified people. The exact combination depends on the service level and local rules. A basic unit may use 2 EMTs. An advanced unit may require a paramedic paired with an EMT or another paramedic. The vehicle may operate nights, weekends, holidays, and every hour between them. One 24-hour position cannot be covered by one employee. The company needs multiple crews to absorb days off, training, illness, vacations, turnover, and overtime limits. That is why payroll dominates the business. The siren may last 15 minutes. The company is paying for the other hours too. In May 2025, national wage data placed median annual pay around $47,000 for EMTs and $63,000 for paramedics. The employer pays more than wages. Payroll taxes, health coverage, workers' compensation, uniforms, continuing education, recruitment, and overtime all sit above the headline salary. A staffing shortage can therefore damage the company twice. The operator pays premium overtime to keep units open. If no crew is available, the operator loses transports and may violate its contract. Now look at dispatch. A call center must identify the location, understand the reported emergency, select an appropriate unit, and communicate with hospitals and public agencies. The dispatcher is managing more than distance. One ambulance may be close, but already transporting a patient. Another may be available, but staffed only for basic life support. A third may be cleaning after an infectious call. The system must preserve enough coverage for the next emergency. This turns the business into a moving inventory problem. The inventory is not the ambulance. It is the next available unit hour in the correct place with the correct clinical capability. A weak operator stations vehicles where they have always been stationed. A strong operator studies when and where calls actually appear. Dynamic deployment can move crews as demand changes by hour, day, and season. That improves utilization. It can also exhaust employees if every quiet moment becomes another relocation. Operational efficiency and workforce retention must be balanced. Now examine the first revenue layer. Emergency 911 transports are the most visible part of the business. A patient calls for help, a public dispatch center sends the ambulance, and the crew transports the patient to an appropriate facility. The ambulance company may then bill Medicare, Medicaid, a commercial insurer, or the patient. The operator often does not know the payer when accepting the call. It cannot inspect the patient's insurance card before responding to a cardiac arrest. Two clinically identical transports can therefore produce very different collections. A commercially insured patient may generate a stronger payment. A Medicare or Medicaid patient is paid under government rules the company does not negotiate. An uninsured patient may receive a large bill that produces very little cash. The price printed on the invoice is not the same as the money entering the bank. This is the second financial trap. The company provides the service before it knows what the service is worth. Medicare illustrates the problem. Its ground ambulance payment normally combines a service level amount with payment for loaded mileage. The service level changes between non-emergency basic transport, emergency basic transport, advanced life support, and specialty care. The payment also changes with geography. In 2026, Medicare's ground ambulance conversion factor is $284.56. The standard ground mileage base is $9.15 per loaded mile before applicable geographic add-ons. Assume an urban pickup, a geographic index of 1, basic life support emergency service, and 10 loaded miles. The simplified Medicare amount is roughly $464 for the service and $93 for mileage. That is about $557 before patient cost sharing and other claim-specific details. The patient may later see a much larger gross charge. The ambulance company may still be limited to the allowed Medicare amount. A high bill does not prove a high collection. The second revenue layer comes from commercial insurance. Commercial payments are often stronger than government reimbursement. They can also be inconsistent. An in-network agreement may offer a negotiated rate and clearer payment procedures. An out-of-network claim can produce disputes over allowed amounts, medical necessity, and the patient's responsibility. Federal surprise billing protections generally still exclude ground ambulance services unless state rules provide additional protection. That leaves patients exposed to bills they did not meaningfully shop for. It also leaves operators trying to collect from people who never expected to become direct customers. A large accounts receivable balance may look like an asset. Some of it may never become cash. The third revenue layer is scheduled inter-facility transport. Hospitals and nursing facilities need medically necessary transfers, and predictable trips can keep crews productive. But not every patient who needs transportation qualifies for an ambulance. Medicare requires the patient's condition to make other transportation medically inappropriate. Scheduled repetitive transports can also require documentation and prior authorization. The company cannot treat every stretcher trip as guaranteed reimbursement. A missing physician certification or weak medical necessity record can turn a completed transport into a denied claim. The crew performed the work. The vehicle used fuel. The reimbursement can still disappear months later. Billing quality is therefore an operating function, not an office detail. The fourth revenue layer comes from higher acuity transport. Advanced life support uses more clinically capable staff and can receive a higher service level payment. Specialty care transport can require critical care skills, specialized equipment, and coordination with hospital teams. These transports may produce more revenue. They also require more expensive labor and lower crew availability. A critical care team cannot be created by placing another monitor inside a basic ambulance. The company needs protocols, medical direction, education, quality review, and enough volume to keep the specialized crew productive. Higher reimbursement does not automatically mean higher profit. The expensive team may spend most of the shift waiting for the right patient. The fifth revenue layer is contract and readiness money. A municipality may pay a subsidy because patient billing alone cannot support the response time coverage the community expects. A hospital can pay for dedicated units that remain available for transfers. A venue may pay for ambulances and clinicians to stand by during a concert or sporting event. A government agency can pay a retainer for disaster readiness and then pay more when assets are deployed. This is often the healthiest kind of revenue. The company is finally being paid for availability, not only transportation. But the contract usually carries performance obligations. The ambulance must be present even when no patient appears. The operator is selling certainty. Failure can cost the contract itself. Now look at the revenue cycle. After the patient reaches the hospital, the medical work ends. The financial work has barely begun. The company needs a complete patient care report. It needs signatures, pickup and destination codes, mileage, service level, clinical documentation, insurance information, and proof of medical necessity. Each payer can require a different workflow. A clean claim may still wait weeks. A disputed claim can wait months. A denied claim may require appeal letters and additional records. In 2024, CMS reported an ambulance improper payment rate of 13.2%. Insufficient documentation accounted for most of those improper payments. This does not mean every improper payment was fraud. It shows how easily documentation determines whether revenue survives review. The ambulance can arrive on time and provide excellent care. A weak report can still destroy the payment. Now consider the calls that never become transports. The crew may assess a patient who refuses to go to the hospital. Another call may be canceled after the ambulance begins driving. A fire department may treat the patient before the ambulance arrives. The patient may be pronounced dead at the scene. The company still used dispatch time, labor, fuel, equipment, and coverage capacity. Traditional transport-based reimbursement may produce no payment. This is one of the strangest features of the business. The company can perform the correct clinical action and create no billable ride. Forcing an unnecessary transport will be medically wrong and legally dangerous. Leaving the patient safely at home may be the right outcome. The traditional payment system can still value that outcome at zero. Now build a simple operating model. Assume the company keeps 4 ambulances staffed around the clock and owns 2 additional vehicles as spares. Across 1 year, the dispatch center sends those units to 10,000 calls. 7,000 calls result in billable transports. The other 3,000 include refusals, cancellations, treat on-scene outcomes, and responses that do not create a covered transport. Assume average net collection of $1,080 per transport across commercial insurance, Medicare, Medicaid, and self-pay accounts. Transport revenue reaches $7.56 million. Municipal and hospital availability contracts add $650,000. Event standby, training, and other contracted services add another $250,000. Total annual revenue is approximately $8.46 million. That sounds like a strong regional business. Now subtract readiness. Field payroll, benefits, overtime, and clinical supervision consume $4 million. Dispatch, billing, administration, and medical direction require another $900,000. Vehicle leases, depreciation, equipment, and replacement costs consume $850,000. Fuel, repairs, medical supplies, uniforms, and decontamination add $700,000. Insurance, stations, software, communications, licensing, and compliance consume $950,000. Debt payments and capital reserves require another $550,000. Total annual cost reaches approximately $7.95 million. The company keeps about $510,000 before income taxes and major surprises. It generated more than $8 million in revenue. Its operating margin is only about 6%. One difficult contract, one insurance shock, or one staffing crisis can erase it. Now change the payer mix. Assume the company performs the same 7,000 transports. More commercially insured patients are replaced by government-insured or poorly collectible accounts. Average net collection falls by only $90 per transport. Annual revenue declines by $630,000. The ambulances did not drive fewer miles. The crews did not work fewer hours. The original profit becomes a loss. This is the third financial trap. The company can become less profitable without becoming less busy. Now change the transport rate. The dispatch center still receives 10,000 calls. Only 6,300 now result in billable transports instead of 7,000. The company loses 700 transports. At the same average collection, that removes $756,000 of revenue. Some fuel and supplies are saved. Most readiness costs remain. The crews were still scheduled. The stations were still open. The company answered almost the same number of calls and produced far less cash. This is why call volume can mislead an owner. A call is operational work. A paid transport is financial output. Now consider rural/metro. The company became one of the largest private ambulance and fire service operators in the United States. It served communities, hospitals, nursing homes, industrial sites, and airports through a broad contract network. Scale created opportunity. It also created financial complexity. Rural/metro filed for Chapter 11 protection in August 2013. Later SEC materials described several causes, including high leverage, aggressive contract bidding, revenue recognition problems, and difficulty accounting for changing payer mix. The company had recorded revenue that did not convert into cash as expected. Decentralized billing operations extended the collection cycle. Acquisitions added more payer rules, reimbursement levels, and collection timelines. The ambulances were still operating. Field performance was not identified as the main cause of the bankruptcy. The financial system above the crews had failed. That is what ambulance company distress can look like. The sirens still work. Patients still reach hospitals. Employees still complete shifts. But debt, weak contracts, billing delays, and unrealistic collection assumptions consume the cash before it reaches the owner. Rural/metro emerged after restructuring and reducing debt. The lesson is not that scale is bad. The lesson is that scale magnifies every mistake in contracting and revenue collection. Now compare that failure with a stronger scale model. MedPAC's recent ambulance cost analysis found that transport volume was the strongest driver of cost per transport. Organizations in the highest volume quartile reported far lower costs per transport than those in the lowest quartile. Dynamic staffing models also reported lower costs than static staffing models. A large operator can spread dispatch, billing, medical direction, stations, technology, and spare vehicles across more transports. It can also negotiate contracts with better data. GMR provides a current example of that network approach. Its filings describe operations across roughly 1,400 counties and long-term relationships with communities and hospital systems. The company reported retaining about 98% of its 911 contracts in 2025. It also uses technology to show local dispatch centers available resources and request units when needed. Scale alone does not guarantee good economics. GMR's own disclosures emphasize fixed readiness costs, payer mix risk, collection delays, and government rates that can fall below transport cost. The strong model works only when volume, deployment, contracts, and billing reinforce one another. The weak operator owns vehicles. The strong operator manages unit hours. The weak operator counts gross charges. The strong operator measures net collection by payer and days until cash arrives. The weak operator celebrates every new contract. The strong operator calculates the true cost of meeting its response time promise. The weak operator schedules the same number of units all day. The strong operator matches coverage to demand without burning out the workforce. Same ambulance, different business. Now ask what a sophisticated buyer studies before acquiring an ambulance company. The buyer starts with contracts, not vehicles. The buyer inspects every ambulance and major medical device. A fleet approaching replacement age can turn yesterday's earnings into tomorrow's capital bill. Ordinary buyers see a row of expensive vehicles. Sophisticated buyers see contracts, clinical labor, dispatch density, payer mix, and a revenue cycle attached to every call. That is the real asset. The future may change what counts as a successful response. Nurse navigation programs can redirect some low-acuity callers toward clinics, telehealth, or other care options. That can preserve ambulances for serious emergencies. It can also reduce unnecessary emergency department use. But the economics must change with the clinical model. If the company is paid only when wheels carry a patient to a hospital, avoiding an unnecessary transport destroys its own revenue. Availability payments, navigation contracts, and alternative care agreements can align payment with a better outcome. So can owning an ambulance company make you rich? Yes, but not because an emergency bill looks large. The strong version secures defensible contracts, receives payment for readiness, builds enough volume to spread fixed costs, and protects its workforce. It places the right unit near the next call. It documents the care correctly. It understands which payer will actually produce cash. It replaces vehicles before breakdowns remove coverage. The weak version buys ambulances and assumes calls will create profit. It underbids contracts, understaffs shifts, ignores payer mix, and confuses gross charges with collections. It waits months to discover that completed transports were denied. From the road, both companies may look identical. The vehicles are clean. The lights flash. The crews wear the same uniforms. The patient reaches the hospital. But one company has converted readiness into contracted, collectible revenue. The other is providing an essential public service while slowly running out of cash. That difference appears after the siren stops. So understand what you are actually buying. You are buying vehicles that lose money when they cannot be staffed. You are buying clinicians whose waiting time is part of the product. You are buying contracts that can create protected demand or permanent losses. You are buying claims that may not become cash for weeks or months. Most importantly, you are buying readiness. You thought the business was the ambulance ride. The ride is only the moment the public can see. The ambulance is not the business. Keeping a trained response network ready and getting paid after the call is.